Good afternoon, everybody. I'd like to thank the panel for giving me an opportunity to speak, and I'd like to thank all of you for making your way here to Vegas and all this uncertainty we're having. I'm very excited to be talking today about what I think is a really cool new field in surgical practice, abdominal core health. I don't have any disclosures. I love abdominal wall surgery, but sometimes it's kind of a drag. People really, I think, perceive us as just hernia surgeons. And I want to be clear, this slide is not things I believe, but things I have heard in my travels as an abdominal wall surgeon, as a trainee and as an attending. When I was a resident, they used to joke that the abdominal wall team was the closing team, that the real surgery would happen, they do some kind of cool colon thing or oncologic resection, and we'd come in and kind of clean up the mess and that sort of thing. I'd kind of be remiss not to, talk about how our PR has taken a big hit with all this mesh stuff. People think that we're just slapping prosthetics in people for no reason and making money off of it. I have this conversation, I don't even know how many times per day. I'm sure you all do too. We don't cure cancer. And what that does is we don't have a ribbon or like a walk or like a celebrity who's really advancing our cause. And this last one I really hate because it hurts me, but, so you're not gonna get to see it? There we go. We don't save lives. That hurts because I think we do more than save lives. We have a profound impact, I think, on patients' quality of life. But if you're looking strictly at kind of taking out tumors, taking out bullets, that sort of thing, we don't do that stuff. And so when you look at public perception of hernia surgery, I turn to I think the most reliable source of public perception, which of course is Facebook. We did an admittedly small poll in the Central Ohio Facebook group, but I think this sort of shows what we're up against. And we had people rank surgical specialties by kind of coolness or perceived prestige. And not surprisingly, transplant and cardiac come out pretty good. They come up about a 9 out of 10. And then way down here at the bottom, scraping by at just under 2 out of 10, is hernia surgeons. We're behind general surgery and colorectal surgery. So clearly, I think our brand has a little bit of work to do in this space. So I'm going to spend this whole talk talking about how I don't think we really are just hernia surgeons, but I want to start by saying that even if we were, that's pretty cool all on its own. Hernias affect millions of Americans, we all know this, and because of that, we do literally millions of hernia repairs per year, 500,000 ventral and 750,000 inguinal repairs. And that costs our healthcare system over $3 billion, and that's not even counting the costs related to mesh complications and readmissions and that kind of thing. Hernia repair is one of the most commonly performed elective general surgery procedures in the country. So again, even if this was all we were, it's still pretty substantial. And the thing is, abdominal wall surgery is really cool and it's really complicated. People come in with these kind of disaster abdomens. Yes, we love the primary umbilical hernias in a 25-year-old. But a lot of times we get things like this, and it requires a lot of quick thinking, a lot of really detailed thinking on your feet in the OR. And these are really debilitating conditions. These are things that really, really impact patients' lives, and I think we have a really, really major effect on it. One of my attendings in training told me that the reason he went into abdominal wall is because hernias are the one thing that Americans are never going to have a pill for. And I think that's pretty true. And I think that, hernias are always going to be the gift that keeps on giving. We know about trauma laparotomies, but this is a study looking at the incidence of incisional hernias in patients undergoing oncologic resections. And they looked at 500 patients and about 2,000 CAT scans. And in the 2 years post-op, this is a graph of patients who have hernias in yellow and patients who don't in blue. And 41% of these patients developed incisional hernias. And when I've shown this slide before, what people will say is, well, yeah, but a lot of these cancer resections are moving towards MIS approaches. But if you look at this graph, 2 of the specialties are broken out, lap and open. And lap nephrectomies still have a 25% hernia formation rate, and lap colectomies have a 53% hernia formation rate. So we're going to be getting a lot of business for a very long time. And I think as everyone in this room knows, though, we don't just treat hernias. These are just some of the diagnoses that come walking through the clinic doors in Columbus. I'm sure many of you see these patients too. The postpartum women with huge diastasis, the fistula from old mesh or from something else, people with chronic pain either from mesh or from sports injuries. And despite the joke about the closing team thing, that really is an important part of those surgeries. Those surgeries can't happen without us there to fix them. So we are already a really multidisciplinary field, even if we're not really branding ourselves that way. So I think, it's really time that we reconceptualize who we are as abdominal wall surgeons and start focusing more on the holistic approach to abdominal core health. So other specialties have figured this out, and my example for this is, you could find a lot of them, but my example for this is going to be colorectal surgery. So I think saying that we're just hernia surgeons is a lot like colorectal surgeons saying that they just do diverticulitis. They do diverticulitis. They do it very well. They do diverticulitis prevention. They do screening. They do the surgeries. They do all of that. But they do a lot more than that. They do the entire spectrum of non-cancer disease, including IBD, anorectal disease, and pelvic floor dysfunction, both of which can be non-surgical much of the time. They also, of course, have a huge presence in the cancer space, both with cancer resections, cancer screening, and endoscopic resections. And so what colorectal surgery and many other surgical specialties have done is really reconceptualize themselves not just as an organ system or even a disease process, but really thinking about how that area of the body affects patient's entire being. And I think that's what we need to do too. So I think the first way to do that is to start by conceptualizing what the abdominal core even means. And I think this comes down to anatomy. The abdominal core is the musculature up to and including the diaphragm and down to and including the pelvic floor, and includes the muscles that extend out laterally all the way to the back. And it's more than just the anatomy. It's really the functional and quality of life metrics that are attached to all of this. And so I want to sell you this idea that hernias are really more than just defects. They really are diseases of the abdominal wall. And so one way I'm going to try and prove this to you is talking about this core stability test that we're pilot testing at Ohio State. This is my boss. He's doing a really good job, Ben Palos. So we have people sit on a ball with their feet dangling, and then we hook up these monitors that capture the weight shifting, essentially, as they sit on this to measure how stable their core is. We use that to develop a core stability composite score. And we compared these for patients who were controls, like my boss, and patients who have hernia defects, both ventral and inguinal, and these are a range, small to large. And not surprisingly, patients that have any kind of hernia, even an inguinal hernia, showed reduced core stability. So just having a hernia defect, even if it's small, really changes how your entire abdominal core functions. This also goes the other way. When we fix the hernia defects, we are in fact treating someone's entire abdominal wall, whether we want to talk about it or not. So here's a study from Canada where they took 21 patients undergoing complex abdominal wall reconstructions. And they had improvements in post-op pain and function and hernia-related things, but they also had significant improvement in their chronic back pain, just showing again how the hernia defect was really affecting their entire function. This is a study looking at those postpartum women that I know we see a lot of in our clinic. They underwent surgical repair of their diastasis, which I know can be controversial, but in this instance, they also had improved cosmesis and pain, but they also had significantly improved pelvic floor function. They had improvement in their urogenital distress score and also improvement in their incontinence, which again, just shows that by addressing something that doesn't seem to be related, we actually have a really holistic effect on these patients. So, what I think is that, that we just sort of change how we think about what we do. And I think that this new field, if it were to exist, should really address more than just hernias. Although it should address hernias and other intrinsic diseases like diastasis. It can also encompass extrinsic diseases like prosthetic complications and benign and malignant tumors of the abdominal wall. And then really this bottom part, we start really looking at patients' quality of life related to their abdominal core. And how are we going to do this? And the answer is a lot of ways. Of course, surgery is always going to be on the table. That is what we do. It's why we go to work every day. But I think there's also a role for physical therapy, which I know we're going to hear about in a minute, both prehabilitation and rehabilitation. Pain management, both medication and procedural. Prophylaxis, closing those abdominal walls really well in high-risk patients may help with incisional hernia from forming. Medical management for patients who don't want to or can't undergo surgery. And then, in a really holistic fashion, kind of looking at some alternative treatments for, abdominal core issues like acupuncture and yoga. So I hope this sounds at least a little appealing to you, but I know that there are some significant barriers when it comes to implementing something, a new thought process like this. And first thing is, change is hard, and I think a lot of people hear this and they think that we're sort of overcomplicating what really is a simplistic issue, and, this really requires a change in how we approach these patients both before, during, and after surgery. This is probably the most common one. If you try and get surgeons to talk about acupuncture or yoga, you get a lot of raised eyebrows. And to be clear, you don't really have to talk to patients about yoga. I'm just asking you to understand that yoga is a thing they can try for their chronic abdominal pain. And this, I think, is a really important one. There is a lot of resistance to the idea of subspecialization, and especially kind of pulling this volume into just certain centers that have these, major abdominal core, resources. And I do think that's something to be cognizant of, but, I think that a lot of this we can do in really any setting. I don't think you have to be at a major medical center to do some of these things. And again, to prove this point, there's a history of success fairly recently, actually. I think acute care surgery has done this very well. Really not that long ago, the acute care surgeons got together and decided to really pool their resources and their school of thought into treating both trauma patients, critical care patients, and emergency general surgery patients. And there was a lot of resistance to this at first, especially people saying that, there's no place for this in smaller hospitals. But this is done really, really well, and it's been shown to improve outcomes, and it works even in small hospitals and rural hospitals all across the board. I think another great place to look is really just probably right next to you. Like there's a bariatric surgeons have done this incredibly well as well. And they've really combined obesity surgery, metabolic surgery, and obesity medicine into one flagship, service, the ASMBS, where they really take a multidisciplinary approach to weight loss, to surgery, and to just metabolic complications of those things. So, even though change is hard, I do think there are some really distinct advantages to us changing how we look at what we do. I'm sort of joking about, public perception of our brand, but I do actually think that changing the way that we present ourselves to each other and also to patients to a brand that's focused more on holistic health and not just a disease state is something that's going to be really good for the field. I also think that, taking a sort of 1,000-foot view, a holistic view of these patients allows for a multidisciplinary approach to what's really a complex issue. And this collaboration will open avenues for opportunities in education and funding, which is always important, and also innovation. I think the more people you invite to the table, the more transformative your care becomes. And the last thing is, that this is really the best care I think we can provide, our patients. I think the more people we have looking at problems from different angles, the better our results are going to be. So in summary, I hope you all are with me on this journey of abdominal core health. But the most important point, I think, is that, hernia surgery is awesome. I love what I do. I think you guys all do too. But it's also extremely complex, and it's getting more complex all the time. So I think our care really needs to evolve to meet the level of complexity that our patients are presenting to us. Reconceptualizing our field allows us and our patients to really better understand their entire pathology, not just the size of their hernia defect, and I think treat it more appropriately. And the last, really the most important thing is that this really is the right thing to do. I don't think any other field has ever opened up their borders, kind of brought in other viewpoints and said that it was a mistake. Allowing more people at the table really does help us provide the best care for the people that we see every day. That's all I have. Thank you so much.